preoperative considerations for total ankle arthroplasty. I think back when we made our decisions to do orthopedics, we probably were sitting in a hospital, getting labs in the morning, waiting for labs to come back in the afternoon, and tinkering meds, and those things weren't fun. So I think as orthopedic surgeons, we've got the pleasure that we can intervene with patients, fix them, and in most cases move on. And so not exhaustive, but just some things that go through the decision-making process, talking with patients and things we need to think about with clearances, coordinating with our other medical specialists as well. So on the kind of left side, ones we just sort of selected to look through, and then on the right side, some of the modifiable ones that the patients come in with that aren't necessarily their medical history, but some of their social history. Just kind of looking at some of the literature, and the AOS and the Hip and Knee Society have their clinical practice guidelines, and so looking at those relative to diabetes and total joint arthroplasty, they looked at A1Cs, and they found complication rates were similar, as well as satisfaction scores, but they did have lower Knee Society scores and WOMAC scores. Looked at infection rates also, and they looked at cutoff variables as well, and 7.7 was sort of their marker where increased infection rates went from 0.5% to 5.4. And so I think, it's already been a little bit alluded to, is with neuropathy. So when we're seeing them in the office, just checking to make sure they're not neuropathic. They may not think they are, but the Semmes-Weinstein, having monofilament before you're thinking about elective surgeries on diabetic patients, is certainly critical and important.